This seminar marks the beginning of a series of such events, which I'm holding to help me formulate views about the lessons to be learnt from the distressing events at Stafford Hospital over the past few years. I've now completed hearing a huge range of witnesses and have received in evidence a vast range of documents, all of which are accessible to you and the public through our website. Of necessity, those hearings focused on what happened in the past and has put under the spotlight of scrutiny the actions of a very wide range of organisations and individuals involved in the commissioning, scrutiny, oversight and regulation of the Trust, primarily responsible for the management of the hospital. The emphasis of these seminars is different. They're intended to look forward rather than back. I want to hear and benefit from discussion and debate around a number of issues which are relevant to determining what changes need to be made to reduce or, if possible, eliminate the chances of another Stafford. Each seminar has a loose overall theme, and today's focus is on regulatory methods. In the paperwork, various questions are mentioned. I should say that these don't necessarily reflect my own views and certainly don't represent any conclusions on my part. I have not and cannot reach any conclusions, obviously, until the end of the hearings, which will not, in fact, conclude until the beginning of December. We've invited you here today as people who seem to us to have relevant and helpful experience to bring to the table. Obviously, the numbers of people we might have invited is absolutely limitless, and no one should feel they've been invited here to represent any particular interest or organisation. And indeed, I very much hope that everyone here will feel free to express their personal views based on their experience. However, I have to give you a caveat. This is a public inquiry. This seminar is public in the sense that the public can attend if they've told us in advance. And the proceedings that were here today can be reported. So unlike most seminars which you go to, I'm afraid I can't tell you that Chatham House rules apply. But I hope that won't inhibit a discussion about issues which genuinely trouble the public and the NHS, and how we all need to struggle, I think, to find a solution to those problems. This inquiry presents a unique opportunity for an overall review of healthcare regulatory systems based on a collection of evidence that is unlikely to be repeated. In his evidence to the inquiry recently, Sir David Nicholson said this, it's not quite properly transcribed, I think, but he said, "You, Chairman, and the rest of the inquiry team have had a unique insight into the way a complicated, vast healthcare system operates. And no one else has had the opportunity that you have, and sad that you have had to have the events to make it happen. But that experience that you've got over the last 120 odd days is unique in the history of the NHS. So it's vitally important, it seems to me, that people like myself and senior people in NHS and in the government commit to learn the lessons that you're going to set out for us as part of this process. And I'm absolutely committed to taking that forward on behalf of the NHS. So no pressure there, you might think. But I'm very grateful to all of you for giving up your time to provide me with some help. One thing perhaps can I say about that help, what I'm after today is not submissions from you in terms of recommendations, but an exchange of ideas about things in the system and what the issues are and how possibly some of them might be put right. But please don't give me a list of recommendations as such. I am obviously grateful to the three speakers who volunteered at really quite short notice to give us the benefit of their wisdom, and I'm sure some thought-provoking observations from their perspective, and also to Dr. Sarah Harvey, who will facilitate this seminar so that I can for once not be a chairman and I can sit back and listen and participate, I hope, as you can. And I hope that your participation will be a little less robust than Lord Justice Leveson had to deal with yesterday. At least I have the advantage of never having tried to prosecute Ken Dodd. Before I hand over to Sarah, can I, though, on a serious note, remind us why we're here? It's because a large number of patients and those who cared about them were let down over a sustained period by the service that they received. You see on the slide just some of the people whose lives have been profoundly affected by what happened. They want not only to know why their relatives were allowed to suffer as they did, they want the system changed to reflect that experience. Some of them have sat through nearly every single one of the 133 days of the evidence we've heard. Let me mention just one case which this inquiry has heard about. Mrs. Asprey died on the 11th of April 2007. She was 66 years old and had been admitted to hospital on the 1st of April via accident and emergency, having sustained a fracture in a fall. She was a known insulin-dependent diabetic, and those accompanying her to hospital made sure that the doctors and nurses knew that. A doctor registered this information and wrote out a prescription for insulin in her drug chart. The administration of insulin was dependent on her blood sugar level, which therefore had to be tested. She needed special dietary attention and assistance, but somehow the referral, if any, to the dietitians didn't get through. It doesn't appear she was given insulin when she needed it. Nursing handovers of the need for insulin, and indeed of its claimed administration, were not recorded, if they happened at all. There was nursing evidence available to the eventual inquest that on one occasion a senior nurse came on duty and found Mrs. Asprey and another patient covered in their own faeces. Mrs. Asprey, was not given insulin when she needed it, and on the 11th of April was found in a collapsed state from which she failed to recover. The pathologist's opinion was that she died through diabetic ketoacidosis following insulin deficiency. An investigation was conducted by the Trust's in-house solicitor at some point after the death. It explicitly identified a number of problems. These are just some of the problems that the in-house solicitor identified, and in a long report there are many more. A letter of condolence was sent to the family on the 18th of April, 7 days after the death, but no indication was given in that letter or at the time to the family of any intended investigation. The report was not given to the family until May 2008, a year after the lady's death. At some point, the matter was reported as a serious untoward incident to the Strategic Health Authority, but so far I've seen no evidence that either the report or the solicitor's investigation report was either read or registered there or indeed anywhere else. The Health and Safety Executive conducted an investigation. An expert report was produced for internal use. It identified multiple systemic failings. I doubt you'll be able to read that, but they include a failure to ensure an adequate communication system regarding Mrs. Asprey's safety and care over successive shifts, failure to document what nursing care was provided, failure to provide the specific care she required, and so on. To date, no formal decision has been taken by the Health and Safety Executive whether to prosecute, but it is not in general the policy of HSE to prosecute in healthcare cases, believing that healthcare regulators are better positioned to address this type of case. The matter was, sorry, the slides are in the wrong order. The Health and Safety Executive wrote to the partner of the late Mrs. Asprey, and said this, that Section 3 of the Act, which in essence requires an employer to conduct his undertaking so as to ensure, so far as is reasonably practical, that persons who are not employees are exposed to the risks to their health and safety, is extremely broad. It is therefore important that it's used appropriately and in accordance with our guidance. It should not generally be used where other regulators, such as the CQC, are better placed to act. The question mark is Mr. Ronald Street. The police investigated the matter but concluded that there should be no police prosecution. The matter was reported to the coroner and an inquest did not take place until September last year. The jury's view of the matter was highly critical. They said they were satisfied that a number of shortcomings were evident, that they were serious shortcomings in the systems and in the implementation, monitoring and management of the systems in place. Nursing facilities were poor, staffing levels were too low, training was poor, and record keeping and communication systems were poor and inadequately managed. The Trust, in the meantime, had been subject to a poor rating by Dr. Foster Intelligence. Indeed, the published rating came out in April 2007, the very month in which Mrs. Asprey died. And at that point, Staffordshire, Mid Staffordshire, had the 5th worst rating in the country. The Trust looked into the matter, and the board accepted the report, a copy of the findings of which are on the screen. And the first conclusion was that the Trust did not believe it had any significant clinical problems which can be attributed to high mortality rates. And as is now well known, a number of criticisms were made about the way in which things were coded. It would be nearly a year before the Healthcare Commission launched its investigation, and a year after that before its report was published. Mr. Street's view of experience of the system was eloquent. In his written statement, he said, "I'm not here for myself, I'm here for Jill and the rest of the dead. I'm not being sanctimonious, I could walk away at any time, but I'm not going to. When they took Jill away from me, they took away my contentment. I don't want anyone else to suffer that. Bereavement comes to us all, but it's how it comes to you that is important." This is, of course, only a snapshot of a tiny proportion of what I have had to consider. But those of you that have not had the opportunity to do so, I do urge you not to read the whole of my report, but I do urge you to dip into volume 2 of it, which contains the stories of some 900 people who gave evidence in one form or another to my first inquiry. There are in there some positive stories, but also a huge number of extremely concerning events that occurred over a long period of time. So my message today and throughout, from my first inquiry onwards, is that however much we might wish and have to talk about systems, regulators, assurance, robust action plans, and other favourite phrases, we must never, ever forget why it is these things are happening. It is because there are patients who deserve and are entitled to safety and good quality service if they're to be provided with a service at all. Well, thank you very much. That's the end of my sermon for the day.